Welcome, everyone. Thank you very much for joining us at the Department of Orthopedic Surgery at the Mount Sinai Health System webinar, What's Moving in Orthopedics. We wanted to take an opportunity to share with you some of the innovative and interesting and wonderful, exciting things we have going on in the department. We're going to highlight four of our scientists and physicians this evening and share with you some of the groundbreaking developments that we're working on in the department. Please feel free to use the Q&A function. That's where I'm going to be monitoring for questions, and we will save plenty of time for questions and discussions at the end. So again, your questions will be anonymous. Feel free to communicate with us that way. And without further ado, I want to start by introducing Dr. Alice Wong. Dr. Alice Wong is a PhD. She works in our orthopedic surgery laboratory. She is an associate professor in the department and is doing some groundbreaking research on tendon healing. She recently won an award, the Kappa Delta Award, which is the highest honor that you can get in orthopedic surgery research for the Young Investigator Award. Alice?
Hi, thank you for that kind introduction. Great. So to start, tendon injuries are extremely common and they account for nearly 50% of all musculoskeletal injuries. So the ability of these tissues to heal is quite poor in that tendon is not able to really rebuild itself. Instead, the tissue actually heals by forming a scar tissue that's not as strong as the original tendon. So the current gold standard of treatment is really surgical repair, where you can suture the tendon back together or suture it back to the bone. However, while this can really improve function and also alleviate pain, it really doesn't rebuild the actual tendon structure. And so to use one example, in the case of a young elite patient, such as this NBA basketball player, a torn Achilles tendon will still take up to 9 months to heal after surgery, with many more months of rehab after that. And this is with the best medical care that money can buy, right? So if you imagine that for this young player, this is still the healing trajectory, how much more of a clinical challenge is it for our older patients with even less ability to heal? And so in the lab, we are really interested in two fundamental questions. Why are tendons not able to regenerate in the same way that bone can regenerate or muscle can regenerate? And how can we induce regeneration after a tendon injury? And so to address these questions, the lab, we use mice for many of our studies for a number of different reasons. So one important reason is we can actually modify the DNA of mice to create mutant mice that can reflect disease conditions. We can also engineer mice that will let us visualize their tendons more easily. So in this picture that you see here of a mouse arm, we can see that the tendons light up with this green fluorescence protein that we've put into the mouse, whereas the muscles show up in red. Most importantly, the tendons of mice are actually quite similar to that of humans. And so this allows us to create clinically relevant injuries in the mouse to study the biology of healing. And so not only does this allow us to understand sort of the basic biology of healing, but it also allows us to test new therapies or drugs or interventions in order to improve tendon healing. And so one area that my lab has really pioneered is in establishing a model of tendon regeneration. And so when I started at Sinai, one of the major problems the field faced was really, we didn't have a model of regeneration. Everybody was saying tendon healing, but using adult animal models. And so it turns out, similar as in humans, adult mice actually can't regenerate their tendons. But what we find is that when we create injuries in baby mice, the tendons can actually grow back in as little as 14 days. When we analyze the mice, we find that they walk normally, they run normally. And when we test the tendons by stretching them, we see that the injured tendons have returned to their normal uninjured strength. And so if you look at the image all the way to the left, you can see this red box where we've highlighted where we've created the injury. And in the middle image, we can see in the baby mice, this new green tissue is now filling in that red box where the new tendon has grown in. Whereas in the panel all the way to the right, in the adult mice, we don't have any green tissue. Basically, there's a lot of scar tissue that fills in and doesn't have like a tendon structure. And so just to show you what this looks like on the kind of whole animal level, here is a baby mouse where we've injured the right Achilles tendon in the limb. You can see it's not really walking well. It's not able to lift up on the paw. Instead, it looks like it's almost walking around on its ankle, right? But by 14 days after injury, the mouse has recovered tremendously, where it's running around, it's able to stand up, use its paw for motion, and qualitatively, it can be very difficult to distinguish an injured mouse from an uninjured mouse. And so in addition to these important mouse models of injury, we have also developed new methods to create artificial tendons in a dish. And so here are these couple of images. I've shown you some tendons that we've been able to grow from mouse stem cells. And we are now actually applying the same principles to grow tendons from stem cells derived from human patients. And so basically the process is we would get a skin biopsy from a patient, turn those skin cells into stem cells, and then grow tendons from sort of these patient samples. And what this really allows us to do is to personalize care, where we can use these tendon avatars to screen for drugs or test therapies or test rehabilitation protocols, because everyone's individual biology is so unique and different. And so in addition to working with other PhD scientists, we also work very closely with orthopedic surgeons on the team. So Dr. Gallatis, for example, and Dr. Parsons, where not only can they provide us with clinical human tissue samples to study, but they also provide their clinical expertise to help us really ground our research in what would be most beneficial to patients. And in the research side of the orthopedic department, in addition to kind of what my lab is doing with tendons, we also have researchers working in spine and joints and muscle and bone. And together we hope to really invent new therapies and improve outcomes for our patients. And so thank you very much. I'll end here.
Thank you, Dr. Wong. That was excellent. Next, I would like to introduce Dr. Doug Eunice. Dr. Eunice is an associate professor of orthopedics and at the Icahn School of Medicine. His practice is based at Mount Sinai West, and he is doing some incredible work reimagining joint replacement surgery in the age of robotics, 3D printing, and artificial intelligence. Doug?
Thank you so much, Dr. Gallatis, and thanks everybody for joining us tonight. So I'm going to tell you a little bit about some technology that my startup, Monogram Orthopedics, is developing that we think really can have the potential to revolutionize a lot of the aspects of joint replacement surgery. And some of you may have even had joint replacements and may be asking yourselves, well, where was this great technology when I needed it? Or you may be asking yourself, you know, why mess with success? My joint replacement came out perfectly. And it's true that joint replacements do generally come out very well, but when you look at how we make the sausage, you know, we're starting with and we do a lot of eyeballing. The implants often don't fit correctly because they're not made for a specific patient. So to illustrate this, you know, here's a patient of mine named Dave, and he's about 4 weeks out from a hip replacement, doing great until he twists the wrong way in the kitchen and he feels this horrible pain. He falls to the ground. What happened? He broke his femur around his hip prosthesis and ends up requiring revision surgery with a lot of hardware to fix it. And why did it happen? Could be that the implant didn't fit quite right. It was an off-the-shelf implant, not really designed for his bone. Could be all the hammering during the surgery created a little crack in the bone. But a lot of these issues can be fixed with technology. Here's a knee replacement patient. This guy actually signed up for a knee after all the trouble he had with his hip. Knee looks good at first. A couple years out, starts to show some signs of loosening because it maybe didn't fit quite right. It's not a custom implant. And again, the thing gets catastrophically loosened. This is the most common cause for revision surgery in knees and hips is loosening. And he, again, needs this big surgery to fix it. So, can we do better in the age of personalized medicine, as Dr. Wong was talking about? Can we go from off-the-shelf implants and kind of crude carpentry instruments to more personalized joint replacement implants to try to fix some of these problems that we have with loosening and poor function? You look at some of the implants that maybe 4 different companies make, and they all look the same on knees and on hips. They're kind of cookie cutter implants that aren't really designed for any one particular patient. But what if we actually, instead of having a crude 2-dimensional x-ray, we had a 3-dimensional reconstructed image, really a roadmap of a patient's bone? And then what if instead of hammers and chisels, we had a very sophisticated robot that could mill to within the accuracy of a human hair, an intricate and precise cavity, kind of like this industrial robot that is used in car factories and all kinds of automated industry. And then what if you could, rather than kind of taking off-the-shelf molds of kind of standard implants, what if you could print anything you wanted to out of titanium really quickly and really economically with a 3D printer? This is just a kind of a look at 3D printing technology, and we can actually print in titanium porous metal structures that are designed to fit a specific patient's bone, and we can do that in about 12 hours. Well, if you had the ability to have that roadmap and have the ability to create any kind of cavity you want with a robot, you could create organic, custom-made implants really designed to fit perfectly. So our platform starts with a CT scan, which is how we generate our 3D roadmap. Our software creates that 3D model and then an implant designed to fit just that patient. And then our surgical robot really gently and precisely mills out a cavity to accommodate that specific implant for a super tight fit and a much less invasive surgery and implant. This is a little closer look at our robot. So the question is, does this work? Does our idea work of moving from off-the-shelf implants and chisels and hammers to robots and 3D printing? And what our data shows is that our knee implant, compared to the leading competitor that's a off-the-shelf implant, our knee implant was about 300 times more stable and much less invasive. Our hip implant was 630% more stable than a leading available implant. So it looks so far from our data very promising, and we're really excited to continue developing this technology here at Mount Sinai and starting clinical trials in the next couple of years. Thank you.
Thank you, Dr. Eunice. That was great. Next, I'm going to introduce Dr. Parsons. Dr. Parsons is Chief of the Shoulder Service for the Mount Sinai Health System, and he also serves as our Vice Chair of Education in the department. He is a professor of orthopedics, and he's going to talk about reaching new heights and rebuilding shoulders. So keeping with the joint replacement theme, but moving to the shoulder. Thank you, Brad.
Thanks, Lisa. And Doug, that was a great segue into my talk. And much like in hip and knee surgery, like you're pointing to, we're doing the same thing in shoulder replacement and shoulder replacement surgery. And the idea we're really trying to gear towards or move towards is patient-specific implantation. And really it starts with planning. And so, if you have the ability to meticulously plan for the surgery, then you can also have a prosthesis design that's going to be able to handle that patient's situation. And just for our visitors tonight, just so you have a sense of what we're dealing with, on the x-ray on the left, this is a normal shoulder. And what we as orthopedists know, and what you probably know if you have had any arthritis, is that arthritis unfortunately causes pain and dysfunction, but it does more than that. It distorts the normal anatomy. And for surgeons, our goal with arthritic patients is to restore their function and relieve their pain. And to really achieve success, you have to get the anatomy back to more normal. And so you can see on the x-ray on the right, the humeral head, the ball part of the shoulder is kind of flattened, and there's a lot of sort of extra bone and distortion. So that makes my job as a surgeon, and all of our jobs as a surgeon, more difficult. And so really, when we think of the shoulder, we think of it as a perfect circle on the ball side. And we want to restore that perfect circle so that all the muscles are in balance. And as Doug pointed to in the hip, we have a stable shoulder that doesn't dislocate or do anything bad. And so that's our goal when we do this operation, is we want to get that anatomy restored to perfect. And what you can't see on these x-rays is we also put a socket piece in the bone that helps make the socket bone smooth again. And when I talk to patients, I really use the analogy of a golf ball and a golf tee. And so we know that in the shoulder, the socket is very small and it's easily eroded by arthritis. So on the illustration on the right, you can see that when the ball starts to get arthritic and rub away and destroy the back of the socket, and that adds to a degree of bony loss, but also instability to the shoulder. And that makes my job, again, much more difficult because I've got to restore that normal anatomy to make the shoulder successful and stable. And we know now from some advanced imaging studies that the distortion can be really severe. So again, on the left, that's a normal socket looking at it, sort of an en face or front view. And on the right, this is a patient of mine who had severe distortive anatomy from arthritis that's really eroded away the socket. And with conventional options, even 4 or 5 years ago, we didn't really have the ability to handle this level of distortion. And so we could try to do things to help the patient, but we might not have the ability to achieve the success and durability that we're hoping for in all of our patients with arthritis. And so just by, again, way to compare, again, we're trying to get that perfect circle on the left. This is a patient that was sent to me who had a joint replacement done elsewhere. And you might not appreciate this, but this is their socket piece that's not even in the bony socket. And this is the ball piece that's supposed to be up here at the top of the arm bone. You can see the difference with the ball and the arm bone here. This ball is way below the top of the arm bone. And so this patient's anatomy was so severely distorted that it caused the implant to get loose and fall apart quickly. And that obviously is not an outcome that anybody wants for their patients. And so how do we avoid this? And really the biggest evolution in shoulder surgery in the last few years has been the idea of virtual planning. So like Doug talked about with getting a CT scan and developing a patient-specific implant, we're taking it one step further. We're taking the CT scan on software, on a computer. I can plan the surgery to be able to position the implants meticulously and perfectly within the patient's bony anatomy. And so I can do it for the socket side, and we can now do it for the arm bone side. And that allows us to make sure the implant's the right size, the right shape, the right orientation, and we can adjust this in real time very quickly on our tablet or a computer. And so when I talk to my patients, I'm talking to them about doing a specific plan just for their shoulder, which obviously everybody thinks is attractive, and certainly it makes my job easier. From that plan, we now have devices that can be made to target to the patient's shoulder in the operating room. So they're sterile equipment. We can have bone models made on the left, which is shaped just like that patient's bony socket, or we can have even devices that mimic the bony socket, which is more cost effective for our institution and for healthcare providers all over the country and world. And so these ideas of targeting from our plan is also critical. And this has been looked at scientifically. So here's a study that was done at the Cleveland Clinic. And what this shows is this is the accuracy of a surgeon, actually a couple surgeons who are world-renowned shoulder specialists, when trying to do just the conventional old-fashioned technique of exposing the shoulder and putting the socket piece in where they think it belongs. And so the scatter of the blue dots is really not in that center square you want it to be. Then they took the ability to take a three-dimensional plan like I just showed you, and just with the plan alone, you can get a sense they're getting around that central square better. And so that's obviously a little bit more precise, a little bit more accurate, but certainly we hope we can do better than that. And then having the ability to target that plan with intraoperative guidance, you can see pretty much everything's right in the sweet spot where we want it. And so really, this is the way we do shoulder surgery and shoulder replacement at Mount Sinai now. This is what our service uses for our patients, and it's made a tremendous difference in the ability to help treat our patients and really have the replacement go just the way we want. Further, there's been evolution in implant design. So now that we understand some of that anatomy better that's been distorted, and we have better ability to plan for that distortion, we now have components that are made, just like Doug was showing, to be able to handle that deformity. And so I've had the privilege to be in some of the design process for some of these implants as well, like Doug. And really, it's allowed us to handle severe deformity in a more substantial way. And so I'll finish with a case of a patient who was sent to me. This is a 76-year-old physician. And just you could see that CT scan that I showed before, where the implant is really just, the anatomy is very distorted. The socket bone is very, very worn. A conventional implant will not work for this patient. And so we now have the ability to make a personalized implant for this patient. And so we take the CT scan. The company that does this makes an implant that goes in the bony socket, which you can see in the illustrative examples on the top. We can actually plan where every single screw is going to go into that patient's bone. So this allows us to not only plan, but target in the operating room. And now we can have a stable implant that restores that patient's function. So for me, this has certainly been a big evolution in my practice over the last 5 or 6 years, and changed the way we handle things, and allowed us to now expand into innovative design, much like Doug was showing. So thank you very much for your attention.
Thank you, Brad. That was great. For our last speaker, I would like to introduce Dr. Melissa Lieber. She is the Director of Emergency Department Sports Medicine, and she's an associate professor in both the departments of medicine and orthopedics. And she's going to talk about how she served the players in the US Open during a pandemic. Thank you, Melissa.
Thank you so much for that introduction. Nice to meet you all virtually. I'd like you all to first participate in a little exercise. And I want you to imagine if you could all in a windowless area about to face one of the biggest moments of your life. You've worked your whole career for this. There's a tough battle ahead. You will be in the spotlight, but you've prepared for your opponent. Yet there is still so much uncertainty. The clock strikes 7 and out you step to the thunderous applause of New York City. Okay, you can open your eyes. How do you feel? No, this isn't the US Open I'm talking about, not this year. This is mine and my colleagues' daily ritual at the height of the pandemic. Working around the clock, often in unfamiliar environments, and yes, our surgeons were on the COVID floors, trying to save as many people as possible, all the while trying not to get sick ourselves. And this picture is of Dr. James Gladstone showing how he's traded in a scalpel for a pulse oximeter. Every night at 7 o'clock, I would step out from the hospital into the thunderous roar of the New York City crowds, cheering for the frontline health workers desperately trying to battle the pandemic. This is not the normal. But what I just described is typical of the US Open, with the world's best tennis players walking out onto Arthur Ashe Stadium at night, each night. But not this year. This year, Djokovic, Naomi Osaka, Serena Williams, they had to battle not only each other on the courts, but also battle all the challenges that coronavirus set before them. But just like they were battling, so were we. This year, with our team of orthopedic surgeons, emergency physicians, and radiologists, including our infectious disease team who had never played a role in the US Open before, the orthopedic department helped put on one of the first major sporting events during the pandemic for the world to see. This year, there were no crowds and there was no cheering. It certainly felt different, but we had a job to do. Each day we showed up to the National Tennis Center, decked out in PPE and treated the top tennis players in the world. But it wasn't just the sprains and strains that we had to contend with. We were now introduced to a new world of sports medicine meets public health. We were now mask ambassadors, contact tracers, rule enforcers, social distancing monitors, and a host of other roles in an effort to ensure the safety of the athletes, their teams, and the limited staff present at the US Open. Although I witnessed some amazing tennis and got to eat breakfast every day with a view many would pay thousands for. And get this, I didn't even have to battle the throngs of spectators trying to make their way into the event. I would give it all up to have the stands jam-packed with fans again. Well, except for the lack of traffic part, because that was pretty amazing, not having traffic getting to the stadium. I'd like to believe that our work as an orthopedics team at the US Open, putting on this event, which brought a bit of distraction to us and the rest of the world, may have been just as important as the work we did throughout the height of the pandemic. Professional sports needed this event as an example, so they could believe it was possible. Although New York City is tough, we needed this event for a sense of pride and belief that we could overcome the obstacles before us. Our patients needed this event, so they knew there was a safe way to return to the sports and activities they love. We, the frontline healthcare workers, walk past this thank you banner each day as we enter the hospital. But I want to thank you. Whether you've donated money or simply opened your window and banged on pots and pans at 7 o'clock at night, adding to the raucous New York City environment that we so desperately crave, your support is greatly appreciated. I am proud to be a part of this orthopedics team, which helped pull off a safe and successful US Open 2020. Thank you.
Thank you, Melissa. Since you just finished, and we have, again, a reminder to our audience, if you have questions, please put them in the Q&A. I'm monitoring that for your personal questions. And some of you did send in questions early, so we're going to get to those. Outstanding, everybody. Thank you. Melissa, when you treated everybody there at the US Open, how did you isolate the players from each other, and how did you keep everybody social distanced there?
Well, there's a very long answer, but I'll try to stick to this relatively short answer. And that is that we had all the athletes and their teams, their coaches, their trainers, all stay at one hotel. So we had to find a hotel in Long Island big enough for everyone. And then all the ancillary staff, who we called Tier 2, stayed at a second hotel. And the Tier 1 players and family and entourages, the Tier 1, including the doctors, and that we all had to be tested every 3 to 4 days. 48-hour tests. So the initial test was we had to have 2 negative tests within 48 hours. And then after that, every 3 to 4 days if you were Tier 1, which meant that you had direct contact with the athletes. And then everyone involved, whether they were the buses driving the athletes to the National Tennis Center, or the athletic trainers the physios taking care of the athletes, they all also had to be tested. And then, interestingly, if you were a top-ranked player, you were kept out of the locker room, meaning I think it was the top 50 players or top 75 all had suites. So the suites that normally the fans buy or purchase, the hospitality suites, those were all used by the players and their teams to isolate from other players and their teams. And then the locker rooms only allowed about 15 players at once. And so that kept everyone able to social distance, as well as did the best to keep people apart. And there were signs all over saying, if you pass this line, you've left the bubble. And if you've left the bubble, you can't compete anymore. And then the other factor is that, Serena Williams, Djokovic, and a few other players all rented houses nearby. But in order to be a part of the bubble, they actually had the same exact security guards. They had to pay for the same exact security guards that the rest of the athletes and teams were using to ensure that they were part of the bubble and make sure that they were not breaking any rules. So even though they stayed in their own homes, they definitely were kept to the same standards, and that way it was kept relatively safe.
Great. I know it was a Herculean effort for you and the rest of the team, and you're right. It was great for New York to have a reprieve from a long and rather isolated summer. So really, really interesting. I want to circle back to Alice. Alice, really, why, what is there something that changes in our biology that like baby mice and younger people will heal? What happens to us as we're older? Do you have any idea what happens to us and why we don't heal things as we age as quickly as we once did?
Sure, that's a really great question, and that's something that we're trying to understand in the lab also. So there are a couple of different factors. One could be the tendon cells themselves are, once they're done growing, maybe they just kind of go silent and they're not able to respond in the same way. But one area we've been really excited about is actually how the immune system changes as we age. So one thing that we know that's been talked about a lot with COVID is how grateful we are that children and babies aren't really affected in the same way as adults, right? And it turns out it's because they don't mount the same immune response to infections the way adults do. And this special immunity that, you know, babies and very young children have. And so what it turns out to also have in our baby mouse and adult mouse models is that there's a special population of immune cells, a special subtype of T cell that seems to be able to orchestrate this unique immune response in the babies when we make a tendon injury, so that there is early inflammation, but then they really quickly tamp it down. And so when we put these special immune cells into the adult mice, we can actually really improve the tendon healing, and I think in adult mice. And I think it's really because of the way these immune cells are regulating inflammation. Yeah.
Thank you. I'm going to turn to some of the questions that were sent in by our attendees. This one is for Dr. Parsons. At 92 years of age, what treatment do you suggest for arthritic shoulders, bone on bone? Cortisone shots were worthless and super painful with certain movements. It's a tough one.
Yeah, that is a tough one. You know, unfortunately, when you have arthritis, there's not a lot of options. And so, you know, when I talk to patients, I kind of break it down into two different sort of scenarios. One is living with it and managing. And we do a lot of things to try to help folks manage, like some of the things this person asked about: therapy, cortisone injections. And for some folks, those work, but often they stop working, as this person may have experienced. And so there are new injectables that may provide some benefit. So there's some materials like hyaluronic acid, which is FDA approved for the knee. And many of us, like you, Dr. Gallatis, and myself, have used that for our patients with shoulder arthritis. And it gives some benefit, but it's not scientifically studied as rigorously as some other things. And so it's in our sort of bag of tricks. And so that's an option for some folks. There's even other injections like bone marrow aspirate or something called PRP, which is essentially concentrating your healing proteins from your body's blood or bone marrow into an injection that we give into the joint. And that's showing some benefit again in knee arthritis with some preliminary data. But unfortunately, like we discussed with Doug and I, when the joint gets really destroyed from arthritis, you're stuck often with trying to manage. And if you can't manage anymore, that's for this person, if they're 92, I will tell you the oldest person I've done a joint replacement on was 94. Very independent person, lived by themselves, had miserable shoulder pain, and had, you know, relatively smooth, easy recovery and regained overhead function and retained her independence. So, you know, we know age can be, as people get older, surgery is a big deal. It's a big deal for everybody, but thankfully, you know, surgery can be very safe and successful even in our older patients. So if it ends up coming to that, even at 92, I think it can be an option if someone's health is good, but obviously that's always the last resort.
Thank you. Question for Dr. Eunice. When do you know you should consider having your knee replaced versus physical therapy? So I guess the question is really, when do you know you're ready for joint replacement? Are there some criteria that you use?
Yeah, I mean, it's elective surgery. So, you know, it's not like, you know, it's not like heart surgery where, you know, you have to have it or you're, you know, you're going to die. So it's always elective. You know, we like to exhaust non-surgical treatments. So physical therapy falls in that category, cortisone shots, some of the things that Dr. Parsons mentioned. You know, there are not a lot of great options in advanced arthritis, but certainly we'll try physical therapy, cortisone shots. Weight loss is, you know, unfortunately something that we often have to recommend and really does help, especially in knee arthritis. And then to answer the question about when are you ready, you know, it's such a personal thing and everybody's life is different and their kind of activity levels different. Their expectations of what they want to get out of a joint replacement are different. So, I have a conversation with them about, what their life is like and what they can expect from a joint replacement, and leave it up to them. I tell patients, you will know when you're ready. And they have to, of course, have the x-ray changes of pain, severe arthritis, 7 out of 10, really bare minimum. But for the most part, I give patients the information and let them make their decision as far as the timing goes.
Doug, one other thing about that answer to that question, someone told me, and I don't know what you think about this, but some people said that you need a joint replacement when you feel like you need a cortisone injection every month. What do you think about that?
Well, I think that's, so like our rule of thumb is every 3 months, is for cortisone. So
right.
Yeah,
right.
so they're getting to that point where they can't last 3 months, where if it's a month, and there are other like real like red flags. Like if they need something stronger than anti-inflammatory, if they really need like opioid stuff, if they really can't sleep, those are triggers where I say, you know what, you're pretty much there.
Yeah, I do only shoulder replacement, not hips and knees, but I always tell my patients, when you can't get a good night's sleep, when you can't do the things that you want to do, and when it's otherwise interfering with your lifestyle and you've tried everything else, it's time for a joint replacement.
Yep.
Melissa, we've got a really great question from the audience here. Were there any serious injuries during the US Open this year? Without disclosing any privacy, of course.
HIPAA in mind. Serious injuries, no major serious injuries that I can think of. We definitely had some COVID positive patients, which I'm sure, players, excuse me, which I'm sure you may have read about in the news. And then they had to quarantine, and there was some, arguments about that because there was decisions about, these athletes traveling all over the world, spending tons of money to come here, having not earned any money in many months because they couldn't compete. And then they had to stay in their hotel room for 2 weeks. And so that, there were a lot of upset athletes and teams because there weren't a lot of, but in general, any major injuries. And the other crazy thing is normally it's super hot during the US Open. And even though it was warm, it was not like the year before where it was consistently like in the mid to high 90s the whole time.
Right. Dr. Parsons, another question from the audience. Have we made any progress on elbow replacement?
Yeah, we have. So certainly elbow replacement is not as common as shoulder replacement, which is not as common as hip or knee replacement. And so, the advances in elbow replacement really have to do with implant design and implants that fit into the smaller bones around the elbow better. And in the way the implants, what we call articulate, which means how they relate to each other and how they move around their axis of rotation. And so the surfaces that are put into elbow replacements are more durable than they were even 10 years ago. And so that allows the elbow to be hopefully more durable as well. And so we haven't had the advancement of some of the planning things that we've talked about with the shoulder and with the hip, but that certainly I would expect to be the next step, because I envision that this will happen to all orthopedics and all joint replacement. It just seems, the way we should be doing it and moving forward and trying to be as meticulous as possible when planning for our surgeries for our patients.
Great, thank you. Dr. Wong, are you anywhere close to finding a solution for replacing lost cartilage?
So, the good news is there's been a lot of progress in understanding how to make cartilage cells from stem cells, and how to make different types of cartilage. So the cartilage that lines your joints versus the cartilage that's going to be replaced by bone, for example. So people can do these things. What's been really challenging for knee cartilage replacement is we haven't been able to make cartilage that's as strong as the tissue that you really need to be functional. Because if you think about the kind of loads that your knee experiences, it's not just body weight. When you're running or walking or all of these things, it's actually many times your body tissue. And so you're asking a lot from a that's been really the main hurdle. People can make kind of cartilage that's non-load bearing really well. And there's really novel 3D bioprinting technologies you can do to shape that cartilage, and for sort of maybe more plastic surgery applications, that's been really great. But I think we're still missing that piece of information to understand how to grow cartilage that's really mechanically tough and strong.
Yeah, which just goes to show how talented Mother Nature is in creating this material, which puts up with so much load.
Absolutely.
There's another question from the audience. I want to talk about joint replacement, and it's about using this technology for revision. So Dr. Parsons, can you comment on revision surgery in the shoulder? And then was going to have Dr. Eunice comment on using these personalized technologies in the hip.
Yeah, so I think that's also been a big advancement in the 16 years I've been in practice, Lisa. Our ability to handle the implant that's worn out or gotten loose or unstable, like that case I showed with that patient, we're now able to use this technology to help with planning. The one factor we have to consider is the CT scan needs to be able to visualize the bone well. And so in some situations, if there's a lot of metal in the shoulder, that can make the CT scan not as accurate or precise in its imaging. But with the newer radiologic technology skills that we have with our radiologic partners in our department and in many of the academic centers in the country, we're able to really get precise imaging even with implants in place. And so we can now use this technology in revision settings. And with the evolution of shoulder implant design as well, we have newer implants designed for situations which, even as I said, 15 years ago, we couldn't handle. So when the rotator cuff is damaged or the bone is really worn down, we can have some of these personalized implants made to handle that more challenging situation. So absolutely, that's really where we're using a lot of this.
Yeah, so the hip is kind of similar to the shoulder, except you walk on it, but it's a very kind of analogous.
Not as elegant.
Not as elegant. But bone loss in a revision hip situation is a pretty common thing, where you can have really essentially a big hole in the pelvis, and it's can be very challenging to rebuild that, particularly with off-the-shelf implants that we have. And we have some good ones where you can almost kind of custom build an implant in the operating room, kind of a poor man's customization, and they work pretty well. But there's some situations where you need a custom solution to kind of fill that complicated three-dimensional hole in the bone. And we've had custom implants that do that for years. The problem has been that there was no 3D printing, when these things were first developed. And so it took it took a long time. It was really, really expensive to do these kind of one-off implants to solve these individual problems. But with the advent of 3D printing and better 3D planning, we can bring the cost and the speed to get that implant to the patient to a much more reasonable place.
Thank you. I have another quick question for you from the audience. If somebody has arthritis in their early 60s, is it inevitable that surgery will be required in one's later years, like in their 70s or 80s?
Inevitable is it's like when you get asked, is there a guarantee that this thing's going to last forever? Nothing's inevitable or guaranteed, so it's kind of case by case. A lot of it depends on why there's cartilage loss. Is there some kind of anatomic reason, like maybe a shallow hip socket, like a type of dysplasia? Is it a genetic, a strong genetic predisposition? Were there some other kind of conditions of childhood that may have caused it? So you kind of have to look at the specific, see if you can figure out if there's something in the history of the patient. But just kind of your average patient with a little bit of thinning of their cartilage in their 60s, it's certainly not inevitable that they're going to have the patient come in periodically for x-rays, and occasionally we'll do a cortisone shot. But kind of like what we were talking about with the knee and the shoulder, when you need that hip replacement, you kind of know it. You really stop being able to do the things that you want to do. But inevitable, probably not in all cases.
Melissa, can you kind of talk about some of the cell-based therapies that you're using to treat arthritis? So Dr. Lieber sees patients in our department as well as in the emergency department, and she treats a lot of patients for arthritis before they're ready for joint replacement. So Melissa, what kinds of things are you excited about?
Yeah, so and it also is combined kind of with the answer to the last question, which is patients always ask, what can I do to prevent a joint replacement? Not that I don't want to give business to Dr. Eunice and the other joint replacement surgeons, but in general, I've found the patients that do the best. This is obviously very simple and not anything I'm doing for them, the ones who are motivated to get strong, especially for their knee joint. So if they are very motivated to do muscle resistance training. So I'm not just saying going walking or doing the elliptical, but I'm saying strengthening your quads, your glutes, your hamstrings, and all the muscles that stabilize your legs and your core. I think those patients do the best by far long-term, even if you have arthritis in your knee, for example. In terms of other options for treatment, we already mentioned the cortisone injections and the hyaluronic acid, which is like a gel lubricant injection for the knee or the hip or the shoulder. The other types of injections, the next one that I'm sure many of you have heard of is called PRP, which stands for platelet-rich plasma. So that's when we take your blood, we spin it down in a centrifuge and inject just the platelets or growth factors or healing factors back into the injured joint. You can also use that for tendons and other areas that are problematic. But for arthritis specifically, there's evidence to show that PRP works very well in mild to moderate arthritis. So in the more severe cases, it really doesn't work as well. But in mild to moderate arthritis, it can work well as part of a maintenance program. It's not going to cure you. It's not going to make it better. It's all part of a maintenance program to try and keep your knee happy and keep it kind of as an anti-inflammatory environment. And so what I tell patients is, if you think of, for example, the knee, if you think of it as like a lawn, if you had a house and you have landscapers that always are putting chemicals down on the lawn, and then you keep up with a maintenance program. There's a spring maintenance program and a fall maintenance program, and you always have to put these kind of chemicals down to have the grass look good and prevent weeds from growing. So if you don't kind of stay on top of the physical therapy, the strengthening, maybe a cortisone injection, or even really the gel lubricant injections frequently, then that's a higher chance of having the weeds grow back or getting these exacerbations or pain. So platelet-rich plasma can work. There's also stem cell therapies, which I'm sure many of you have heard about. Not as good evidence for them in terms of what we were hoping for them to replace cartilage in the joints. So that's not quite as good, but we do try everything, especially in the patients who really want to avoid the joint replacement.
Thanks. Dr. Wong, kind of wanted to circle back to your tendon. So really interesting to see those little tendons growing in the dish. What kinds of things are you trying on those? What's the latest and greatest that you're looking at to try and improve the way those tendons function?
Yeah, so one application of that model could really be to screen drugs. There are really very limited options in terms of biologics to treat tendon injuries. So Dr. Lieber and Parsons mentioned PRP, and one drawback of PRP potentially is that we don't actually know which growth factors are in there. It's just whatever we're getting from blood. So in many cases, it could be very beneficial. In some cases, maybe there are other factors in there that's not so beneficial. So we can use our little 10 avatars to now screen different compounds, sort of small molecules of defined origin and chemical structure where we understand the pathways involved that they activate, and screen sort of thousands of them at once to see which ones are going to make worse, right? So that could be one way where we can really do a high throughput drug discovery platform to find these therapeutics that would be really helpful for tendon. And you could really do this for cartilage as well. I think people have tried to do these things for cartilage. One issue for cartilage specifically is we know how to make cartilage, we just don't know how to mature it to make them stronger, right? So there needs to be sort of invention of a platform to do that. But for tendon, we're even in much earlier stages than some of these other tissues. Like we've gone so far with cartilage, but with tendon, we don't even know really the early factors of what makes tendon. So a lot of basic questions still have to be understood. And this could be one way where we can kind of jump that hurdle and try to find something that's that could be used in our patients a little bit quicker.
Thank you. I want to talk about outpatient joint replacement. This is something that many people in our audience may have heard. So more and more we're starting to do joint replacements. I mean, if you look 10 to 15 years ago, people were in the hospital for a week, and now hip and knee replacements are in the hospital for 2 days, and most of our shoulders go home the next day, and we keep getting shorter and shorter. So Dr. Parsons, where are we in terms of making shoulder replacement a procedure that you could have and go home and sleep in your own bed and eat your own food?
Yeah, no, I mean, it's happening now, Dr. Gallatis. I mean, we are able to take some patients, our younger and healthier patients who unfortunately have arthritis at a young age, and do their surgery as what's called an ambulatory procedure. So we make sure the patient's prepared to have postoperative pain management, often with a nerve block that they can go home with. So it keeps the arm numb for a couple of days so they don't have as much or really any post-surgical pain. We can arrange for them to have their therapy set up so that they can go the day after their surgery to therapy or have someone come to the house. And so this is happening. Our big challenge with our patients over the age of 65 is the federal government right now and Medicare does not allow a hospital to get reimbursed for a patient who's having a shoulder replacement as an ambulatory procedure. And I think the same is for hip and knee replacement, but Dr. Eunice can correct me. And so, you know, that's where we're trying to advocate for our patients because a lot of our healthier patients who are over 65 could do this as an ambulatory procedure as well. And obviously we have to balance the patient's medical issues, any comorbidities they have that put them at risk. Those patients really need to stay in the hospital to keep them safe. But people with really no other medical issues other than an arthritic joint, we're doing sometimes even more complex surgery in an ambulatory fashion. So it just makes sense that some of these joint replacements can be done. And that's, I think, advantageous. Patients don't necessarily want to stay in the hospital. They want to go home. They want to be in their own bed. They want to just make sure they're not going to have a lot of pain and they're going to be safe. The trend that we see growing. That's very doable now moving forward.
Great. Dr. Eunice, how are we doing in terms of ambulatory hips and knees?
Yeah, I mean, I think Brad brought up a bunch of good points. I think, you know, we've been moving toward that goal over the past few years. We're doing a pretty good percentage as outpatient from the hospital. Knees have come off the inpatient only list for Medicare recently. So that's going to kind of help accelerate that move. You know, and then ultimately we're hoping to move to an actual surgery center environment as we kind of hone our pathways. But I think, you know, the key to the whole thing is understanding that it's really multidisciplinary and it's not just the surgeon. You know, we're just one part of the whole machine that makes it happen. It's, you know, social work and physical therapy and anesthesia and everybody's got a role to play, and it's got to all be kind of coordinated, and there's got to be a pathway. And you know, I think when those pieces are in place, it's pretty doable to do outpatient hips and knees in a good percentage of patients.
Yeah, when I looked at the statistics last, we were doing probably a third of the patients qualified for outpatient knee replacement. And I know that Dr. Parsons has done some in our surgery center. So we definitely are able to serve patients in that way. And the joint replacement team has done an incredible job putting together that coordinated pathway. So it's been an interesting journey for the field of orthopedics to really push that along. And you two have really been trailblazers in terms of getting that done. So, so we have about 5 more minutes. We haven't gotten any more questions from the audience. So if there are any other questions that anyone would like, again, please put it in the Q&A. Probably time for one more question. I just wanted to ask Dr. Parsons, you serve as our Vice Chair of Education, and here at Mount Sinai, we have 35 residents. And just address how we were supporting those people through the educational process during the worst of it when really their training was so interrupted.
Yeah, no, as Dr. Lever pointed out, you know, impressively, our faculty and our house staff, our trainees stepped up tremendously during the pandemic. I was proud as a program director to get a note from one of the chief medical officers of Mount Sinai, who talked about our residents serving overnight on COVID units, doing, you know, respiratory care, which they haven't done, you know, often since medical school. And they said to me that of all the residents who chipped in and helped all the different services, the one service they didn't have to worry about getting the job done was orthopedics, which obviously fills me with pride. And, you know, as far as our educational platform and what we've done, we did have some urgent and emergent orthopedic surgery that had to be done during the pandemic. People still get hurt, but our didactic curriculum, the big transition has been like this. So just like we're having a Zoom meeting tonight, our curriculum now to teach our house staff in the morning sessions is virtual, so they can log on from wherever they are. It's actually made the logistics of it a little easier for our residents. They don't have to try to go from one spot to another to be there in time for conference. There's many resources nationally from our orthopedic colleagues and our American Academy of Orthopedic Surgery that is giving residents and fellows expanded curriculum that we're using as well. And thankfully, it was a short period of time for a couple months where we really had to slow things down. And like many things, the department has ramped back up. There's a lot of patients who were put on hold because of the pandemic, and they were really wanting their hip or knee done, or, you know, their shoulder done, and were miserable. And so they've sort of made up for lost time, so to speak. And so the situation, and, you know, I think like anything, our department has done that. I think our residents have not suffered for their education through this process, and they've had an additional experience and challenge that I think will make them stronger physicians, you know, once they're done training, without a question.
Thank you, and thank you for your leadership during this time. So we're getting pretty close to the end of our hour. I just want to take a moment to thank everybody who joined us on the webinar. We're very proud. I'm, as chair, very proud of the work that everybody is doing. I couldn't have my entire crew on the webinar tonight. We just wanted to highlight a few things. So thank you, Dr. Parsons, Lever, Wong, and Eunice, for taking the time out of your busy day to join me here. Again, thank you to our participants. All of the innovative things that we discussed tonight are made possible by our generous supporters. And so I want you to know how grateful we are. And again, thank you for joining us, and feel free to communicate with us through the development office and the people who reached out to you. We are accessible to all of you in any way, and if we can help you, please let us know. I think we're going to put the flow code back up. But again, thank you so much for joining us, and keep in touch.
And hopefully we could do this in person at some point soon.
That's right. That's right. We did have an event last year that was in person, and as soon as we are able, we will do that again. So thank you all for joining.
Thank you, everybody. Have a wonderful night.
Thank you.